Hi, everyone. Welcome. Thank you for joining us. We're going to get started in just a few minutes. Give it one more minute and then we'll jump in. Right. Hi, everyone. Welcome and thank you for joining us today. Before we jump in, just a few things to note. We will set aside time for a Q&A session at the end. So please submit any questions in the Q&A box and we'll try our best to get to as many as we can. Also, a quick reminder that this webinar is being recorded. I'll go ahead and introduce myself briefly. My name is Halima Madi-Monticalvo. I'm the Vice President of Research and Evaluation at Unitas. I'm an epidemiologist and a social and behavioral scientist by training. And I have over a decade of experience working specifically on veteran mental health and suicide prevention projects. And I have the pleasure of moderating today's webinar. I'm joined by three fantastic panelists who I will introduce shortly. Let's go ahead and get started. So as I mentioned, I'm thrilled to have you join us today for this really important discussion around addressing unmet needs for veterans' health and well-being. We have an expert panel here with us today, and they will discuss the latest research, real-world interventions, and opportunities for improving veteran health through policy, provider collaboration, and community support. And this is a critical conversation, of course, as we explore innovative solutions to best serve those who've served our nation. So let me take a minute and introduce our stellar panelists. We have today with us Dr. Doss. Dr. Marguerite Doss is an assistant professor in the Division of General Internal Medicine at the University of Colorado Anschutz Medical Campus. Her research is focused on addressing workforce and system-level barriers to SDOH program implementation and development for veterans. She has experience with understanding veteran social needs and care transitions and implementing social needs screening and referral programs across clinics and hospitals. We also have with us Lori Murphy, who is a senior social worker at the Central Ohio VA and a VHA Innovation Ecosystem Senior Innovation Fellow. She led the enterprise-wide diffusion of Compassionate Contact Corps, which is a volunteer-friendly phone call program that she helped to develop to increase veteran social connectedness. And today, Lori is leading non-clinical care innovation in VA with a goal to improve efficiencies in connecting veterans to community wraparound services. And we also have with us Dr. Kristen Becerra. Dr. Becerra is a combat veteran, having served overseas in Afghanistan. She spent 10 years enlisted in the United States Army Reserve as a psychological operations staff sergeant and instructor. She received her PhD in clinical psychology at Palo Alto University, where she studied suicide and resilience factors for service members and veterans. She also has her master's in public health from Johns Hopkins University, where she concentrated on public mental health, health communications, and health education. Dr. Becerra also has a master's degree in counseling psychology and counselor education from the University of Colorado, Denver. And she's currently working at the Department of Veterans Affairs Center of Excellence for Suicide Prevention as the Associate Director of Education, focusing specifically on developing, disseminating, and evaluating national training and education programs aimed at preventing and reducing veteran suicide. She's also the Worried About a Veteran communications lead in charge of all dissemination efforts and partnerships for this important initiative. So all this to make the point that we have a truly expert panel that can speak to this topic, and I'm looking forward to robust discussion today. Before we jump into the discussion, um, I want to take a couple of minutes and set the stage and highlight why this conversation is so important. So as you can see on the screen, we have close to 16 million military veterans in the US, and this represents around 6% of the total adult civilian population. So when we talk about addressing veterans' health-related needs, it's really crucial to recognize that health outcomes are influenced by more than just healthcare access. Now, veterans frequently encounter non-medical obstacles that can adversely impact their overall well-being. Veterans are at higher risk of homelessness compared to the general population. Many veterans, especially those with low incomes or disabilities, struggle with consistent access to nutritious food. So that's when we talk about food insecurity. Also, transitioning from military to civilian employment can be difficult, right? With veterans facing challenges like skill translation, workplace discrimination, and economic instability. And if we think about it, financial insecurity can also contribute to other unmet needs like housing and food that we discussed. So there are different social drivers that can influence our overall well-being, and in this for this conversation specifically around veteran health. And our panelists will dive in and give us more information about some of the topic areas that I just covered. Um, the other thing I wanted to quickly point out, of course, this is just a snapshot, but in the recent years, we've had a number of publications specific to veterans around how social drivers of health impact overall health and well-being. So I wanted to highlight a couple of these studies here. One study that was published last year by Montgomery and colleagues showed that veterans who received homeless services actually had reduced odds of suicide compared to non-participants in this specific study. Another study showed that the greater risk of ED use or emergency department use was among those veterans who had experienced food insecurity, legal problems, and housing instability. So there is increasing evidence highlighting the importance of addressing unmet social needs for this population. Let me shift gears quickly and talk about the UNITAS data. So since its founding in 2013, UNITAS has launched a variety of networks to address the needs of veterans and military families. And as a veteran-founded organization, we are uniquely positioned to assess and address social needs while also assisting veterans in gaining access to the services that they need. And our approach really can be summarized in three broad categories. So our approach drives the collaboration needed for those serving veterans and their families to, number one, identify and understand community needs to inform strategy, to then deliver services by effectively engaging the right populations and collaborating with local partners to connect them to the resources that they need. And last, our platform can facilitate billing and reimbursement for covered services provided by the community. So when we filter to military affiliated individuals served in our networks, so what you see on the screen, we find that over 295,000 cases have been referred on behalf of more than 112,000 individuals to date. And the majority of these individuals, so around 90% of them, fall under the veteran category as opposed to active duty, reserve, or National Guard members. And of these 112,000 plus military affiliated individuals, 42% of them fall under the 18 to 44 years of age. 81% of them identify as male, and 51% identify as non-white. And if you look at or focus on the map on the screen, the states with darker colors have a higher density of military affiliated clients, with the darkest blue indicating our networks have served approximately 10% of all veterans residing in that state. And here are the top 5 service types for veteran and service members in our networks. So as you can see, housing and shelter, followed by income support, followed by benefits navigation, employment, and individual and family support. So what this means is that these are the top requested services for military affiliated individuals in our networks. All right, with that background in mind, I'm gonna stop sharing my screen and we'll begin our discussion. All right, so Marguerite, Lori, and Kristen, we're so happy to have you with us here today and to learn from you. You each have impressive careers around understanding and addressing the complex issues that our veterans face, including the role of social factors. As leaders in your respective fields, what initially motivated you to focus your careers on these important areas? Was there a particular experience or insight that drove your passion for this type of work?
I'm happy to kick things off if that's okay.
Yeah.
So 6 or 7 years ago, I was working as a social worker at the Central Ohio VA and kind of going down some rabbit holes around addressing loneliness. I was having a lot of conversations with my colleagues across several different healthcare disciplines about our common experience of interacting with veterans who were very profoundly socially disconnected. We would call them up for what was meant to be just, a 5-minute check-in phone call to follow up on some resource or a quick appointment, and end up on the phone for an hour because they had a listening ear and they wanted to share about what they made for dinner last night or about their pets or just talk. And at the end of those conversations, they would tell me, just thank you for listening. And, I haven't talked to anybody else in days, weeks, sometimes months. And so recognizing kind of the universality of this loneliness experience, and then again, across these different disciplines, we were all seeing how this was really impacting some health factors. And this was just kind of observational data. So that kind of sent me down this rabbit hole of looking at the research. And there's decades worth of research showing that chronic loneliness isn't just this kind of sad story to tell, that it has really profound impacts on somebody's health risk. So physical health risk, mental health risk. And that led me to looking into programs. So what can we do about it? What can I offer the veterans I'm working with to get more socially connected? And so all of this kind of research investigation and starting up programs and looking for what's out there hit up against the pandemic.
Mm.
And, the pandemic really amplified this topic of loneliness because across the globe, so many of us experienced loneliness and isolation. And, a few years later into the pandemic, our Surgeon General at the time, Dr. Vivek Murthy, released his public health advisory about loneliness. And so this just really sparked in my career a lot of interest in how can I better help veterans to connect to existing amazing programs out in our community? How can I help build up internal VA programs to address social connectedness? And then that kind of led to, the co-occurring social needs that, of course, come up with social disconnection from, lack of transportation to food insecurity and all those others that you've mentioned earlier. So that's what really sparked in my career how I got involved with all this.
Amazing. Thanks for sharing. Marguerite or Kristen, whoever wants to jump in.
I can jump. Oh, Kristen, you go ahead. Okay. I am a nurse by training, and so I worked on a cardiac step-down unit in Pennsylvania. And while I was in Philly, I kept having patients that they were constantly being readmitted. But what I was seeing as a nurse was that it was because of more social factors, non-clinical needs that were bringing readmissions and ED visits and really affecting their healthcare. And so as a nurse at the bedside, I think I realized that this was not a systemic change that I could make to try to address my patients' social needs in my own work, but I wanted to find a way to do that. And so I actually went to get my PhD in nursing because I thought, can I research this? Can I figure out how to answer this question and create system level solutions that were really working to address these patient needs and keeping them out of the hospital, aging in place, more time at home, and being able to meet those needs. And so that kind of started my work, my career in SDOH and health equity. But along the way, I also did a lot of research on the workforce, the clinician workforce, the nursing workforce, and realized how important, particularly in a strained healthcare environment, it is that we need clinicians to do this work, but also clinicians are really, really burdened in their roles currently. And so what I've set out to do is how do we optimize the clinicians and non-clinicians in our healthcare systems to try to implement these programs, and how do we do it in a way that fits into their existing workflows and also really aligns with their goals and understanding how social needs impact health, mental health, physical health, all of those different aspects. And so that's what I do in my role, both at the VA and the university, to really help understand how we can optimize these programs for SDOH implementation. So Kristen, I'll pass it to you to round us off.
Okay, thank you. So my origin story kind of is a little bit more lived experience, but I was thinking about this, and when my interest started peaking around veteran suicide prevention, and I had the thought in high school. I had a friend who had a lot of suicidal ideation that I helped through. I would think I was in ninth grade at the time, and it was like, those teen beat quizzes, if anybody remembers those, where it's like, are you depressed or not? Like, there were all these different ones, like, does this boy like you, or whatever. But the depression one, I was like, reading through on the phone this quiz because I thought it was funny. And the answer or the question was, have you ever thought about killing yourself? And the answer from my friend was yes. And as a ninth grader, I just remember, okay, I think I have to tell somebody. I know I have to tell somebody, and working through all that, it just kind of set me up for feeling like it was important work. And so kind of fast forwarding into where I am now, I went to school for school counseling, actually in Denver, Marguerite, and and there weren't any jobs at the time. I think it was 2011 for school counselors. So I'm like, I've always wanted to join the reserves. This is a good time. A little bit older now. I can, it's quite a bit after 9/11. The war is kind of winding down. This will be good for me. But as soon as I joined, they immediately sent me over to Afghanistan, where I served there for a year. And along with some of the issues that I experienced within in the combat scenario, I actually had some insight into the mental health going on with me, and not being able to knowing, but still knowing that I had to process through it. And same with reintegration back into civilian life, same thing. It was very difficult, even though I'm like, hey, I know this stuff, but the skills translation was hard. And then I noticed a whole bunch of my buddies that I deployed with are having similar issues or going through different things. And a lot of different social factors that we've already touched on a little bit. So I was like, I want to do something. So I got my PhD in clinical psychology, but while I was doing it, I'm like, this one-on-one stuff, it's great. But I think I need to make a bigger impact and kind of spread that. So during my PhD program, I got my master's in public health, so I was able to do that. And so I really kind of found a niche in being able to bridge the gap between mental health and public health, specifically around veteran suicide. So very excited to be speaking about this today.
Wow. Amazing. Like all these origin stories, really, I think I'm just thinking about some of the questions that I have for you all. And I feel like we can talk about this for hours and hours. One question, Marguerite, I was curious, based on your experience in the context of research, what are the most pressing unmet needs among veterans today? And of course, Marguerite, you can kick us off, and Lori and Kristen, feel free to jump in.
Awesome. I think we all have unique perspectives on this, so I'd love to hear Lori and Kristen's views as well. But Halima, I know you showed, through the United States, the most common unmet social needs, but in veterans at the VA, through some of my roles, what we're seeing is that we're seeing our top two social needs as social isolation and loneliness, and then digital needs, which I think the digital needs piece is also some part of not everyone's screening for digital needs, particularly in the literature. So that would be access to stable internet, a phone, or a tablet. And we have, in some cases, I think there was a recent publication from one of the VA Office of Health Equity groups that about 40% of veterans in their study experience digital needs. And so I think that this is something that we don't often screen for and can overlook, which is fundamental really to accessing healthcare, particularly as we move towards more technology solutions, augmenting healthcare and clinicians, but then recognizing that there might be a lot of veterans who don't have access to stable internet, a phone, a tablet, being able to access telehealth or other ways that kind of also spread out and intersect with all of the other social needs or demographics that might go alongside that as well. And so I think Lori can speak to the social isolation and loneliness piece a lot, but I will say I just wanted to highlight that as something I don't think we're discussing very often, but can be such a problem with access and rural veterans and other groups as well.
Yeah. No, that makes total sense. I mean, digital determinants of health is a huge subfield, that we're paying attention to as well. Lori,
I would just add on that, kind of to piggyback on what Marguerite was saying. Navigation of those services is also a pretty big co-occurring unmet need. So when veterans are socially disconnected or having digital needs, figuring out how to get themselves connected to the resources that might be out there is a really big vacuum in our service trajectory right now. What I hear from a lot of veterans is they are aware that there are programs out there that might benefit them, but they don't know how to actually get to them. So that bridge over to how to learn how to use the tablet they may have received from some service, or how to actually get the confidence to go out to one of these social connected groups and meet new people. Getting connected to the services that can support them is a real big unmet need right now, the navigation.
Yeah, that makes sense. Kristen, anything to add?
Yeah, I'll hop on to that. Speaking of social networks and support, kind of flipping over to the veteran suicide by gun, I think is another thing to think about. So about 75% of veteran suicide are by gun, and that was in just 2022 alone, as excuse me, as opposed to about less than half, or about half in non-veteran deaths. And about a quarter, or I would say about a third of the veteran gun owners store at least one or both guns locked, or sorry, excuse me. Let me just, okay. 1/3 of veteran gun owners store at least one gun, both unlocked and loaded in their house. And this could be for a lot of reasons: hunting, collecting, home protection. And for the veteran, typically they have more experience handling firearms than the general population. So I think what one of the problems is that this is a very sensitive topic when we're talking about not only veteran suicide, and firearm use and secure storage. I feel like these conversations between providers, family members, social support, it's a very uncomfortable conversation to have with somebody who knows way more than we think we do as civilian, or you think you do as a civilian. So having these kind of difficult conversations and setting up not only the individual, as Lori was saying, but also, and I know you're going to talk about this more, Lori, but the social support network and the families and the providers, so that they feel more comfortable having these tougher conversations.
Yeah. Moving on to demographic factors. How do you all think demographic factors like age, race, gender, and service history impact a veteran's access to and experience with healthcare?
I think one thing, I'll just keep talking, I guess. Marguerite, you can jump too. When you're thinking about veteran suicide, in the latest VA annual suicide data report, the 18 to 34-year-old population is the highest among veteran suicide deaths, if you're looking at the unadjusted rates. So trying to figure out what's going on with this age group. And typically, if you think 18 to 34, and really the conflicts in Afghanistan and Iraq have ended over 10 years ago now, you have a lot of people that are having these suicidal thoughts, feelings, and actions that haven't combat deployed. So what's going on with this population, and how can we figure that out?
Yeah, that makes sense.
There's
Lori?
also a real issue I was going to add for kind of the military demographics, so service members and veterans. There's a real identity with supporting their fellow veterans. So what we hear a lot is, I don't want to use that service or connect with that resource and potentially take it away from another veteran, which on the surface is a really admirable, selfless perspective. But on the flip side, it's preventing them from accessing services that they truly do need. And I think us in the healthcare and social service industry understand that one person accessing a resource does not typically mean that it's not going to be available for someone else. But that ethos of from the military of helping your fellow brothers and sisters has trickled down into a real severe impact on accepting help from the services that they need.
Yeah. Marguerite, anything to add specifically? I know your research also focuses on rurality. Anything on that?
Yeah, I can echo Lori that actually in a rural veteran cardiology care access project that we've been hearing a very similar theme of, we don't want to necessarily use transportation resources because they could be limited, but I think we see a really big intersection between different demographic factors, social needs, and rurality. Up to about 25% of veterans live in rural areas, and that can cause different disparities for rural veterans. It's harder to provide resources, to give tailored resource guides for certain social needs, harder to get transportation, access to care. And a lot of times they live farther away from the VA. Though I will say, I think the VA does a great job of having a lot of community clinics to connect care, but higher acuity care often can happen really far from home. So they're farther from social support and other really important factors of their community when they do receive more acute care. And so we're seeing that as it comes through in veteran preference and where they receive care, and then also their ability to access resources and referrals for social needs within our veteran population as well.
Yeah. Thanks for that. So PTSD, suicide, and other mental health challenges are often at the forefront of discussions when we talk about veteran health. And I'm wondering, Kristen, if you could touch on what are some lesser known but equally critical issues that veterans face?
I think coming from lived experience and from research, one thing for me is culturally competent care for veterans, culturally centered care. And what does that mean? I think we could start with the first thing I think of is maybe separating out. We talk about, let's do a military cultural competence training, and really breaking that down. If we're working with veterans, we don't want to call it military culture training because military is its own culture, and the veteran culture is its own culture, because they may identify with some of those military values, and well, a lot of them do, of course, but it is a separate identity, and changing that identity from a military person into an identity as a veteran can sometimes be really sticky. But as providers and family members, kind of piecing apart that difference is really important, I think, is a good first start. And yeah, so when we do a lot of what I've seen from a lot of military culture trainings, are learning about, providers are concerned about, I don't know ranks, I don't know branches, I don't know this, and this about the military. And my argument is like that all is, it's more about how you are sitting with the person. I think, I forgot who said it. I think Marguerite, you might have said it, but like listening and just being connected to the person and really connecting through emotions. Like, so you haven't combat deployed, but can you connect through, okay, that sounds actually really scary. I've been scared before. So connecting through the emotions versus connecting based on experience, because even my experience is very different than any other service member when we were in. So that's one. And then just thinking about generational differences in provision of care too, and the different needs of each of those cohorts. I mentioned 18 to 34-year-olds, but the 75 plus veterans are also, they have different issues, and they serve different wars, and that means different things for them. So those are a couple of thoughts.
So important, especially the focusing on cultural competency, cultural fluency, because that's how you either have the client or the patient's attention, or you lose them. So yeah, absolutely agree. Marguerite or Lori, anything to add? If not, we can move on. I do have 1,000 questions for you, so.
I was just going to add, I think the maybe lesser known but important factor in mental health is social connectedness. So a big part of my mission has been to spread awareness to veterans and clinicians about loneliness and how it impacts mental health, that it increases the risk factor for depression, anxiety, suicide, and really treating social connectedness like any other positive behavior, health behavior. So think of our attention in healthcare on having a healthy diet, getting in enough movement in your day, getting those 8 to 10 hours of sleep every day, however many hours you're able to squeeze in. But adding into that, the importance of having regular social connections. And the research doesn't really point to a specific number of connections that you should have in your day-to-day or week-to-week life to be healthy. It's more about looking over the span of your social connection sphere and seeing, do you have different relationships that are filling different buckets? Do you have somebody that you can contact in an emergency? If you need immediate help with something, do you have that person? Do you have somebody that fills that kind of emotional health bucket when you're going through something that you need to talk through? Do you have that person? So making sure they kind of span all the different value systems that you might have in your life. Getting that information out to veterans and making sure they understand the value of social connection in addition to all those other healthy behaviors is a really important factor moving forward.
I'm so glad you brought up social connections. So we talked about veterans, knowing or identifying, okay, I do have a person that I can call or etc. Um, what role do you think family members and caregivers play in supporting our veterans with unmet needs? How can we better support them? Lori, if you could kick us off, because I know you do some caregiver research as well as part of your work.
Yeah, I think in healthcare and social services, we have finally started moving away from seeing individuals as just these silos and from providers just interacting like robots with this one person. We're recognizing and moving into that philosophy of whole person care and recognizing that healthcare isn't just about prescribing medications and doing lab work. It's about really looking at that whole person, and that includes their social support system. And I think VA specifically has done a really great job at leading some of that direction for healthcare, particularly through our caregiver support program. So this is a program that supports the caregivers of disabled veterans. Those caregivers can be family members, they can be close friends, whoever that veteran has identified as their main support person. And VA recognizes and provides them with the supports they need to serve in that role, from offering different resources and supports to offset some of the financial impact on being a caregiver, but also looking at the whole picture of being a caregiver and how to juggle that role with everything else you probably have going on in your life. We talk to caregivers a lot about you are not just a caregiver, you are also potentially a spouse, a sibling, might be a parent. And all of those roles are really important. So juggling all of the demands from these different roles can be something that's tough to navigate. And our program really has, or the caregiver support program really has the expertise to help caregivers through that journey, so they can then in turn better support their veterans in navigating their healthcare and their social needs. I think it's been a really healthy evolution of healthcare, and also to support veterans who want to age in place. And to age in place, you typically need a support system, a caregiver, if you have disabilities to that level. So I'm really impressed and proud of VA, how they've really supported and built up services to help out those caregivers.
Yeah, that sounds great. Kristen, I'm wondering if you could tell us a little bit more about the worried about a veteran in the context of caregiving and providing support to
Oh,
our veterans.
absolutely. And I love, Lori, what you said about the veteran isn't in a vacuum, because that's kind of the the whole gist of Worried About a Veteran and the initiative that I'm working on. So this initiative started as a New York State program, um, and kind of morphed into a national program now. But we did interviews with veteran spouses and loved ones with lived experience, from suicidal ideation all the way to suicide death. And we found a couple things that suicide and firearm death by suicide. It's a tough conversation for loved ones to start. They don't want to cause a fight. The veteran may not want to worry their families or feel pressured by them. And so it's kind of hard, or extremely hard, to get veterans participation in gun storage. So we tried to fill a gap and an information gap for veterans' loved ones, so that they didn't feel so alone in the process, and being able to start conversations that they feel more comfortable with. So there are resources out there to help, but the worriedaboutaveteran.org website is an initiative that takes the unique approach to preventing veteran gun suicide, through the spouse, loved ones, and even veterans that are concerned about their friends. So no one really does this in the field at this point. So what it does is it empowers loved ones to prevent veteran gun suicide, and has something for every step of the loved one's journey. So from helping the loved one feel less alone by normalizing each stage, to educating them on how to bring up the sensitive subject of secure gun storage, to ways to build trust with the veteran, strategies for starting a hopeful conversation. And one of the newest parts on the site that's really exciting is legal information on each state's storage options, with a map that you can click on each state to find out what your state's legal information is. There are other helpful programs too, like Veteran Spouse Network and Blue Star Families, that have an actual training curriculum for families during transition, or the effects on the family of PTSD and how to navigate that and other veteran-related issues. So there are things out there that are really exciting in that space.
Yeah, such important initiatives. And this is actually a nice segue to my next question for the panelists. Just jumping into from a policy and systems perspective, what are some other successful interventions that you know of that have helped improve veteran well-being? Maybe Marguerite, you could kick us off.
Yeah, absolutely. I mean, I think one of the first steps in this process is obviously identifying if a veteran has social risk factors and has a social need that they would like met. And so the VA has developed a program called Assessing Circumstances and Offering Resources for Needs, or ACORN as its more fun name. And I know Lori and Kristen have also worked with some of the ACORN team members, but ACORN really is a two-component system where you have social risk factor screening that's tailored to veterans, tested on veterans, gotten a lot of feedback from veterans. So we're really specific in asking questions that are more towards the veteran context versus the overall patient population. And then the provision of relevant resources and referrals to address an identified need if a veteran is interested in support for that need. I think the VA as a healthcare system is one of the most robust kind of social support and integrated healthcare systems in the country. So we have more things that we can provide for veterans than a lot of other places can. And so it's a really unique way to tap into the resources that veterans have access to. But I think Lori mentioned earlier, it can be really hard to know how to access those resources or that they exist in such a large system as well. And so I think from a policy perspective, and the system program, we've seen from the Joint Commission requiring or recommending social needs screening and health-related social needs factors. That's helped expand a lot of, I would say, hospitals' interests, community organizations' interests in increasing their screening and really being able to reach a large number of veterans. I think thousands of veterans have been screened at this point through ACORN and other screeners to try and be able to better support their unmet social needs.
Thanks, Marguerite. Lori or Kristen, anything to add?
Yeah, the ACORN initiative that Marguerite was talking about has really been a game changer to have this standardized measure to evaluate how many veterans are experiencing unmet social needs and really drill down to the facility level on what those needs are. And as she shared earlier, social isolation and loneliness has consistently been the highest rated unmet social need for veterans. So one of the programs I've kind of hinted at it earlier that I helped develop during the pandemic is Compassionate Contact Corps. So this is a friendly phone call program where we're really leveraging our volunteer force. Marguerite, I think earlier also talked about leveraging not only just clinicians, but non-clinicians. And so this is a program that really looked at our valued volunteers in VAs across the country and how can we kind of use them to help support veterans' non-clinical care needs. And this was a really great solution, especially in the heyday of the pandemic when the volunteers couldn't come into clinics, but they could make a phone call. And that really made an enormous difference for a lot of veterans who were especially isolated at that time, but we also had been isolated much before the pandemic and continue to have those issues. But I'll also say that I really used the growth of Compassionate Contact Corps. It went from 8 facilities to over 120 in about 3 years. But we used that growth to really also amplify that research that I've talked about loneliness. And really apply that research to clinicians. They aren't getting that education in medical school and nursing school about how loneliness impacts their patients. But the data is there showing that it increases risk for heart disease and infection risk and suicide and depression, as I mentioned earlier. So getting that information to them, showing them the data, kind of speaking to the scientific brains of these clinicians, is then having this great trickle down effect where that information is now being shared with their patients in their appointments, with their caregivers, with their family members. And so slowly but surely, we are seeing a greater awareness through this kind of systems impact about loneliness and about social care and the need to really look at these proactive factors in reducing risk for much more costly health issues down the road.
Yeah, that's so important. Yeah, Kristen, please go
Yeah,
ahead.
and using the community too. So not only family members, but community too. And I'm just thinking about like the importance of gatekeeper trainings. There's growing evidence that gatekeeper trainings for suicide prevention of veterans to assist veterans are becoming more and more researched as a great intervention to start, or prevention, right? So and there's a lot of different ones out there that are wonderful, like VA Save, and that could be found on the PsychArmor website. I know that the American Legion has Be the One campaign, and they have a nice training as well. So educating yourself on those types of things, and then counseling on access to lethal means. Training is also there. It's not geared specifically toward the veteran, but actually CALM is, we consulted with them on the Making of worriedaboutaveteran.org site. So they have a lot of information there too. But I think the more we can educate ourselves as providers, family members, community members on the problem of suicide and the ways we can intervene from nationally recognized programs like these, the more prepared I think we can feel about talking about the difficult subjects like that.
Yeah, 100%, especially when it comes to training. Marguerite, you've talked about, workforce training, identifying that, for example, social isolation is a risk factor, for suicide, or, lack of social connectedness could be a risk factor. That's really important. All right. So let me, before we open up for the audience questions, I do want to ask one last question. What gives you hope about the future of veteran healthcare? And where do you see the biggest opportunities for progress?
I'm still unmuted apparently, so I will go. I think just in my little section of the earth here, my little slice of the pie, I think it's really, really exciting that the conversations are happening more about veteran suicide and specifically veteran gun suicide, and sitting people down at the table with very sometimes opposing views and getting them at the table for one common goal of preventing veteran gun suicide. So there are programs and initiatives happening as we speak with gun owners, with gun shops themselves and their owners, and bigger gun communities, and mental health providers. And it's kind of never been done before, but those conversations have started happening. And I think that's kind of a key to facing this problem.
Yeah, it's great. Lori or Marguerite?
Yeah, I can pop in. So one of my favorite things to do is just to bring together pockets of people who are really kind of doing similar work and just kind of seeing the magic happen. And I've been able to have that experience over and over here in the last couple years, and I see a lot of potential moving forward. And I'm talking about pockets of clinicians, researchers, veterans, caregivers, patients, and then community organizations who are all kind of independently talking about these non-clinical or social needs and how they're impacting health, and wanting to better facilitate connections and referrals to the amazing work that's going out in communities, the amazing resources available within VA. And as I'm working on bringing together all these folks, I see light bulbs going off all the time. And I see a lot of very organic enthusiasm about where we can take this, how we can leverage technology moving forward to better coordinate care across all of these systems. There's huge potential here. I think we are just at the tipping point of what these interconnected systems could really look like and the impact that that could have on health outcomes, on healthcare costs, and on quality of life for our patients. So I think that's really exciting.
I love those light bulb moments and also bringing in those different pockets of people, bringing in people with lived experience, that's my favorite, having all of those people at the table and then seeing the magic happen, as you said, Lori. Marguerite, please go ahead.
Yeah, I agree. I think those light bulb moments are so important. And I'll just echo that I think what's given me so much hope is seeing how rapidly we've been able to spread so many programs and the number of veterans we've been able to touch in just a few years. I think accelerated with COVID and, like Lori said, technology and optimization. And so I think kind of my hope for the future is that we really can prepare and optimize our healthcare workforce, non-clinicians and clinicians, to help implement these programs, and then how we can augment those with technology. So not replace any clinicians, but really have a good partnership and relationship, because especially I think in today's healthcare context, we need to learn how to work together. And I agree with Lori, we are really just on the tip of the potential that we have to bring these things together and really support healthcare workers to do the important work, to do the work they want to be focusing on and address social needs in a way that doesn't create an overly burdened healthcare system. So I think there's a lot of hope for the future.
I agree. All right, let's jump into some audience questions. All right. One question we have here is, do you have information on the difference between female and male veterans with regard to social disconnectedness?
So I don't have any data on that, but I'm going to refer folks to a couple things. First would be the loneliness report that the Surgeon General released a couple years ago. It is probably the best summary of all the decades worth of research out there, and it talks about a lot of demographics and how those relate to loneliness. So I would look at that. And Dr. Holt Lundstad, she was a contributor to that report. She is kind of the subject matter expert on social disconnection. So I would look her up, Dr. Holt Lundstad out of Brigham Young University. I know she's done some research on demographics and how those interact with loneliness. So I would send you there.
Thanks, Lori.
I can just,
Yeah.
oh, sorry, Helena.
No, go ahead, Margaret.
I can just say I can briefly share that I worked with a women's health clinic to help implement social needs screening and referral. And from our early data, so this is not anything that is can be generalizable, but we were seeing still for younger women veterans that social isolation and loneliness was by far the most common social need that we were seeing in, I would say, more women in their 20s, 30s, and 40s. And we are trying to do more research into that. And I think it's a really unexplored area that needs more research to help understand the specifics and the drivers behind that.
Yeah. And I was just going to add that we can link some of the resources that Lori mentioned in the follow-up email that we'll send. Another question we got is around how can the public, policymakers, healthcare providers, and community organizations work together more effectively to bridge gaps in care for veterans? Any insights there?
I can pop on. I think coming to things like this, joining in the conversation, community organizations who are veteran serving and are assisting with social needs, participating in these discussions and making sure we know what kind of value you're adding in your communities. So I think building up those relationships is really key. I know that can be challenging and difficult. There's a lot of players out there, but getting yourself into those discussions is really a key part of it. I think these are really complex issues. There's a lot of co-occurring needs. And every community looks different. Within the VA, a lot of times we say one VA is one VA. So every VA medical center looks and operates a little uniquely, but that can also be said about any community. Every community is really unique. So I think understanding the context of what's going on in a community and what kind of social support that area might need is a really big factor in kind of seeing where you can fit into that whole network of support.
Yeah, thank you. All right, let me see, how are we looking with time? Yeah, I'll take one more question here. And I think, Kristen, you may have answered this question, but in case there's anything additional, what programs or interventions do you recommend that are successful to mitigating the suicide by gun issue?
Yes, I did mention them, especially worried about a veteran.org. That's the newest one. There's also counseling on access to lethal means. There are the gatekeeper trainings, and I will shoot those over to you, Halima, so we can share those links out too, so you have all that information.
Great, thanks, Kristen. Any other resources?
Oh, and then I would just, actually one more thing. We were talking about, I see a lot of like demographics questions, especially around suicide. And I would really point people to the VA annual suicide data report. And that's kind of the report for finding out stats about women, minorities, other social factors. And so I definitely direct you there as well. And it comes out every year, usually in the fall. So the one that just came out for 2024 came out, I think, in December-ish. So would refer you there too.
There's one more question that I want to highlight. Any research and assistance available for women veterans with dual maternal health and mental health challenges? You know, that's specific, but any resources that you all are aware of?
I know that there are. I just don't know what they are. I'll look for some. That's a great question. I'll look for some. And I know there are some out there. So more to come on that.
Yeah.
There are also the VA Women's Health Report, to circle back to another report, actually has a lot of data around that. There's not as much data collection on social needs or health-related social risk factors, but I would definitely recommend that report as well, on top of the others that have been mentioned, to get more data about that.
And we'll link some of these reports that our panelists have brought up during the Q&A. All right, I think I need to wrap it up, but thank you all for great questions and for spending this hour with us. We'll make sure again to follow up on some of the questions that we couldn't get to. If you're on a computer or laptop, you can actually scan the QR code that you see on your screen to get in touch with our personnel, if you have any questions about Unitas. And if you prefer, you can also visit unitas.com to connect with us. We'll just pause on the screen for a minute in case you all want to look at the QR or scan the QR code. All right, and I do want to take a minute and just kind of wrap us up. We've explored a lot of topics here. Like I said at the beginning of the webinar, we could talk about these different topics for hours and hours. But what we explored today was around addressing the social drivers of health and how it's essential in holistically supporting our veterans. It's also clear that by working together across sectors and organizations, we can more effectively increase well-being and improve health for our veterans. I hope that you have found this webinar informative. I want to thank our panelists for sharing their unique and valuable insights. Thank you, Lori. Thank you, Kristen. Thank you, Marguerite. And as a reminder, we will send a follow-up email with the webinar recording. And if you're interested in connecting and continuing the conversation, please feel free to reach out through our website. And thank you all and have a great day. Take care.